Thank you very much for having me here, and continuing in the theme of simulation, I want to share with you this afternoon the results of a great collaborative effort between WCM-Q and our colleagues at HMC in developing an OSCE curriculum for assessing resident communication skills. I have no disclosures. So I'll briefly touch a little bit on needs assessment, on how the idea for this project and the need for this project came about, but most of the talk today that I want to focus on is curriculum development and how we went about formulating and implementing this curriculum, and then I'll talk a little bit about our outcomes so far. This is an ongoing project currently in its third full year. So to set the context a little bit, this is a program that we do with the Internal Medicine Residency Program at HMC, which is a 4-year residency program, PGY 1 through 4. This program for the communication skills is specifically for the PGY 2 and 3 residents. Currently, we have about 80 of those residents coming through the program every year. So as part of the paradigm shift to competency-based education, with this program being in the first batch of programs to receive ACGME-I program accreditation about a year ago, there was a need identified specifically to assess residents' communication skills in a standardized setting, and this was the drive for the creation of the curriculum. And so the framework of the curricular goals are based on the ACGME-I core competencies, specifically interpersonal skills and communication and professionalism, and then within that in some of the ABI milestones, and then within that in some of the specific goals of the internal medicine curriculum at HMC. So our overall broad goals were an assessment method that targets communication skills, professionalism, and the application of these skills with clinical knowledge, like I mentioned, in a standardized setting. And this was meant to be formative, to get feedback to the residents and to give them pointers to grow in these skills. So in terms of the curriculum, it's a 12-case, 2-year OSCE curriculum with standardized patients that the residents do. They do 3 cases in the fall and spring in 2 consecutive years. So what I'd like to talk about is the components of the curriculum. We started with the blueprint development and then went on to case development, implementation, and then evaluation and feedback. And perhaps I should have depicted this, and this is more of a circular rather than a linear model, because of course this is a changing and evolving curriculum. There hasn't been a time where we haven't tweaked or changed something. So I want to start talking about a little bit of the blueprint development. Like I mentioned, we based it on the core competencies, and we identified some, let me see if I can get this, some core topic areas, and then we identified the settings, so there would be a mixture of settings. There's a case complexity, the 2 letters, either the case can be a simple case, and the patient can be complex, or vice versa, and then this complexity increases as the resident proficiency in these communications increases. So for example, for the second years, we have a consent case that's simpler, and then for the 3rd-year residents, we have a CC consent case. It's a complicated case with a complicated consent. And then the primary skills, the competencies, which I mentioned, for most of them, they're interprofessional communication skills and professionalism. And then these are the specific cases for that year. So this is just a snippet of the PGY curriculum. In terms of case development, there are several components. Of course, when talking about OSCEs, everybody thinks about the case history, which details the detailed competencies and milestones, and then the details of the case. The SP notes that have a wealth of background information. Because these are communication OSCEs, not all of them start with the history, or not the usual history physical discussion. Some of them, the resident is given a scenario where they already have a lot of this information, and then they're asked to go into the room and disclose a diagnosis, or negotiate a treatment plan that the patient is in the moment disagreeing with, or something like that. Of course, materials, development of checklists. We developed a standardized checklist with some case-specific rubrics that I'll share in a second, and then the doorway information, which is what the resident receives before they walk into the room, and reviews with any relevant background, physical exam, or lab findings, and instructions on what they're supposed to do when they enter the room. So in terms of the checklist creation, we looked at a lot of resources, and we decided to go with recommendations from the Kalamazoo consensus statement, because we found that sort of the clarity of this document fit with sort of our need to compress everything to a very easily understandable checklist. So the Kalamazoo essential elements include opening the discussion, gathering information, understanding the patient's perspective, sharing information with the patient, and then reaching an agreement on whatever problems have been discussed and the plan for these problems, and then providing closure. So based on these core elements, we created a standardized checklist. I know you can't read this, but these are sort of the core elements with the sub-questions that are standardized, and then so they're standard across all the cases, and then each case has some specific detail. So for example, I think you can read this. This is a part of the rubric from a back pain case where the resident is supposed to explain these components, and then the rating is done either not done, done, or done well. And I'll talk about who does that rating. And then also for each case, there's a global assessment. One part of that assesses the resident's overall communication skills, and then the other global assessment part addresses the resident's ability to address that specific issue that the case focuses on. So in terms of once we developed the core of these cases, there had to be a lot of fine-tuning and standardization of all of these elements. So we first went to the SPs, who helped us a lot. We're very fortunate to have a very experienced and excellent pool of SPs. So actually, initially, they gave us a lot of feedback on case development and case flow, prompts. We have, I think I mentioned that, I neglected to detail on the other side, that's very important for case standardization. We have sort of minute-to-minute case flow, so everything that's going on in room A is going on in room B, with very specific verbatim prompts, so that if a resident misses something, they don't miss out on the entire rest of the case. So the SPs helped a lot with this details, background, and case flow. And then we did, of course, with role play with them. And then we sat, because the SPs give the feedback and they do the rating, so we did a lot of exercising on SP score standardization. So watching cases, videotaping cases, having the SPs watch cases to make sure that everybody was on the same page on how to score them. And then finally invited some very unsuspecting general internal medicine fellows who walked in and kind of role-played the cases for us cold. So to get a flow from somebody who doesn't know what's going to happen, and that was very helpful. And then on the day of the OSCE, before the day of the OSCE, we do an evaluation, an orientation where we give residents information, and we actually show a videotape snippet, and then we give them a sort of the standard checklist to look at, so they know ahead of time what are the things that we're going to be looking at, but they don't know the specific content of the cases. And then on the day of the OSCE, they also have a short orientation. Each patient encounters 10 minutes. They have 3 encounters right now. And then there's a post-encounter period where they fill out the same checklist the SP fills out, so they do a self-assessment, and then they get a sort of in-the-moment feedback from the SPs, which is 5 minutes. And then the SPs also complete the checklist. And then at the end of the whole exercise, they evaluate the entire exercise for that day. That's the evaluation. So in terms of the more global outcomes, we're now in our 3rd year with I mentioned 2 sessions a year with 3 cases. I'll show you a little bit of we have a lot of feedback, but I don't have time to show it all, but residents rate the experience very highly, especially the immediate feedback sessions with the SP. So SP feedback tends to be very targeted, and the residents find it very helpful. These resident assessments, they're formative, but they become part of the semi-annual evaluation. And I showed the global competence. Residents who don't meet or near competence, they have to review their interactions, and then they get more specific feedback, and they have one of the members of the committee is now in charge of that remediation to look at what went wrong and what it is that they need to improve on. More globally, the resident scores and feedback have also been really useful to us to look at general areas in the residency program where the residents as a whole need more training, and I'll show a slide that shows one of the cases or a couple of the cases where we have gotten this information. And overall, we've found that this curriculum is relatively easily replicable. It's, other than the SPs, it's low resource and adaptable to other settings, and it's been a good experience for the residents here. So for example, this is from the spring evaluation from last year. This is part of the global evaluation that the residents do at the end. So it's the overall evaluation of the OSCE experience, and then this is the feedback session that they usually uniformly rank really highly, and then this other one is the content of the sessions is consistent with the learning objectives for the residency curriculum. Some of the cases have been developed based on resident feedback, so of course it matches what they think their needs are. And this is a example of the global assessment. So these were 3 cases from fall of last year. This was a complicated family conflict case, a medical error case, and a CT consent case. And you can see that even though this was a complicated CT consent case, those residents who were rated confidently competent or demonstrated mastery, this was much greater here than in the medical error and the family conflict case, which residents do a little bit less of, and they're much more uncomfortable with, even in their self-ratings. So those are some of the things. There's a lot of data, but those are some of the interesting things that we've gotten out of looking at this so far. So in terms of future plans, we need to do some further validation and really expansion of the curriculum. Part of that, we're limited by faculty numbers, limited by space and time at the moment, but we would eventually like to use the OSCE as part of the summative evaluation, but we're just not quite there now. And then, as I mentioned, further development of the residency curriculum in terms of communication skills to cover those areas of weakness. And then we have plans for, I don't know if one of the posters details, we have very detailed plans for a faculty development program to grow our capacity to expand this program, and also other residency programs have approached us because, of course, communication skills are important not only in internal medicine, but for all healthcare practitioners. So thank you. I just want to give a special thank you to Dr. Dabia and Dr. Ahmed, who work with the residents at HMC, who have made all this possible, and of course all the SPs, without whom, of course, none of this would be possible. Thank you.